Welcome to this Step 2 review on Pediatric Gastroenterology test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will encounter for pediatric gastrointestinal conditions on your board exam and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to re-teach the entire topic. You should be reviewing the Pediatrics and Gastroenterology sections of First Aid and your question bank alongside this video. Our focus is on recognizing patterns and applying strategic thinking on exam day. Here is what we will cover in this video. First, we will learn to recognize high-yield question stems for pediatric gastroenterology conditions, including acute gastroenteritis with dehydration, pyloric stenosis, intussusception, appendicitis in children, and constipation with encopresis. Second, we will apply specific test-taking strategies for dehydration assessment, recognizing surgical emergencies, and distinguishing functional bowel disorders. Third, we will master the next best step question format, which is one of the most commonly tested formats on board exams. Make sure your foundational knowledge is solid before diving into these strategies. Let us start with our first strategy, which is the vomiting pattern split. When you see a vomiting infant on the boards, the first question you need to ask yourself is whether the vomiting is bilious or non-bilious. This single distinction changes everything. Bilious vomiting, meaning green or yellow-green emesis in a neonate or young infant, is a surgical emergency until proven otherwise. The boards want you to think malrotation with midgut volvulus immediately. The next step is always an emergent upper gastrointestinal series. Do not get distracted by other answer choices when you see bilious vomiting in a newborn. On the other hand, non-bilious projectile vomiting in a 3 to 6 week old infant is the classic presentation of pyloric stenosis. Look for the hungry baby who vomits right after feeding and wants to eat again. The boards love describing an olive-shaped mass in the right upper quadrant. The metabolic derangement is hypokalemic metabolic alkalosis from losing stomach acid. An ultrasound showing a thickened pylorus confirms the diagnosis. Our second strategy is the age-based abdominal pain approach. When a question stem gives you a child with abdominal pain, the age of the child is your strongest clue. For infants and toddlers under 2 years old, think Intussusception when you see episodic colicky pain with the child drawing up their legs, current jelly stools, and a sausage-shaped abdominal mass. The classic triad is intermittent abdominal pain, vomiting, and bloody stools. An air or contrast enema is both the diagnostic test and the treatment. Keep in mind that a lead point such as a Meckel diverticulum is more common when intussusception occurs in an older child. For school-age children and adolescents, right lower quadrant pain that started around the belly button and migrated is classic for appendicitis. McBurney point tenderness, rebound tenderness, and guarding are the buzzword exam findings. The boards also test atypical presentations, such as a retrocecal appendix causing flank pain. A computed tomography scan is the best diagnostic study in older children, while ultrasound is preferred for younger children to avoid radiation. Now let us go through the high-yield stem patterns you need to recognize instantly on exam day. The acute gastroenteritis stem will describe an infant or young child with acute watery diarrhea, vomiting, and a low-grade fever. The question will focus on signs of dehydration such as decreased skin turgor, dry mucous membranes, and decreased urine output. The key is to assess the severity of dehydration to determine the correct fluid management. The pyloric stenosis stem will describe a 3 to 6 week old firstborn male with progressive non-bilious projectile vomiting after feeds. The baby is hungry and wants to refeed. Labs will show the classic hypokalemic metabolic alkalosis. Ultrasound confirms with a thickened and elongated pyloric muscle. The Intussusception stem will describe a 6 to 18-month-old child with sudden episodic colicky pain, leg drawing, current jelly stools, and a sausage-shaped mass. Diagnosis and treatment is with air contrast enema. Let us work through our first practice question together. Read this stem carefully. We have an 11-month-old boy with 3 days of watery diarrhea and vomiting. His mother reports decreased wet diapers. On exam, his heart rate is elevated, mucous membranes are dry, skin turgor is decreased, and capillary refill is 3 seconds. He is lethargic but arousable. The question asks for the most appropriate initial management. Take a moment to think about what pattern you are recognizing here before we go through the answer choices. Let us walk through this answer step by step. Step 1. Spot the pattern. We have an infant with multiple days of diarrhea and vomiting, the exam findings of tachycardia, dry mucous membranes, decreased skin turgor, prolonged capillary refill, and especially the lethargy all point to moderate to severe dehydration. The lethargy is the critical finding that tells you this is not mild dehydration. Step 2. Apply the rule. The board rule here is that moderate to severe dehydration with signs of hemodynamic compromise requires immediate intravenous fluid resuscitation with an isotonic crystalloid bolus, typically 20 milliliters per kilogram of normal saline. Oral rehydration is only appropriate for mild dehydration where the child is alert and able to drink. Step 3. Eliminate wrong answers. Choice A, oral rehydration therapy at home, is wrong because this child is lethargic with signs of significant dehydration. Choice C, intravenous dextrose-containing maintenance fluids, is a maintenance fluid and not appropriate for initial resuscitation. Choice D, oral antibiotics, is wrong because most gastroenteritis is viral and antibiotics are not indicated. The correct answer is B, intravenous normal saline bolus. Here is our second practice question. We have a 4-week-old firstborn male with 5 days of progressive non-bilious projectile vomiting after every feeding. He is hungry and eager to refeed after vomiting. His weight is below birth weight, indicating failure to thrive. On exam, a small firm mobile mass is palpated in the right upper quadrant. The question asks for the most appropriate next step. Think about what diagnosis this pattern suggests and what the question is specifically asking for. Let us break down this answer. First, read the question carefully. This stem has every classic feature of pyloric stenosis: a 4-week-old firstborn male, progressive non-bilious projectile vomiting, eager to refeed, weight loss, and the olive-shaped mass in the right upper quadrant. But notice the question asks for the next step in management, not the definitive treatment. This is a critical distinction that the boards love to test. Now, why does ultrasound come first? Abdominal ultrasound is the gold standard diagnostic test for pyloric stenosis. It will show a pyloric muscle thickness greater than 3 millimeters and an elongated pyloric channel greater than 14 millimeters. Even though this clinical picture is highly suggestive, you must confirm the diagnosis before proceeding to surgery. Choice C, surgical pyloromyotomy, is the definitive treatment, but you would not go straight to the operating room without imaging confirmation. Choice A, an upper gastrointestinal series, can show the string sign, but ultrasound is the preferred first-line study. Choice D, switching formula, does not address the mechanical obstruction. The correct answer is B, abdominal ultrasound. Now let us review some key appendicitis pearls for the boards. The classic presentation of appendicitis is periumbilical pain that migrates to the right lower quadrant over 12 to 24 hours. Associated symptoms include anorexia, nausea, vomiting that comes after pain onset, and a low-grade fever. On exam, look for McBurney point tenderness, a positive Rovsing sign, which is pain in the right lower quadrant when pressing on the left, and the psoas sign. An important pearl is that children under 5 have higher perforation rates because they present atypically and diagnosis is often delayed. For diagnostics, a computed tomography scan with contrast is the imaging study of choice for suspected appendicitis in adolescents and older children. Ultrasound is preferred in younger children and thin patients to minimize radiation exposure. Treatment is appendectomy, and antibiotics are given before surgery but are not a substitute for surgical intervention. The boards commonly test the next best step when a patient presents with right lower quadrant pain and fever, so be ready for that question format. Here is our third practice question. We have a 9-month-old, previously healthy boy with sudden onset episodic screaming and drawing up of his legs. Between episodes, he appears calm and comfortable. He has had 1 episode of vomiting and his mother noticed a reddish jelly-like stool. On exam, there is a sausage-shaped mass in the right upper quadrant. The question asks for the most appropriate next step in management. What classic pattern are you recognizing here? Let us work through this answer. First, spot the classic pattern. This is a textbook Intussusception presentation. You have all the key features: a child between 6 and 18 months old, episodic colicky pain with leg drawing, current jelly stools, and a sausage-shaped mass. The classic triad the boards test is intermittent abdominal pain, vomiting, and bloody mucoid stools. When you see this combination, you should recognize Intussusception instantly on exam day. Now, know the key distinction. Air contrast enema is both diagnostic and therapeutic for intussusception. It confirms the diagnosis by showing the intussusception and can reduce it successfully in most cases. Surgical exploration is reserved for cases with signs of peritonitis, free air suggesting perforation, or failed enema reduction. A computed tomography scan is unnecessary when the clinical picture is this classic, and it would only delay definitive management. Stool culture and observation would be inappropriate for a surgical emergency. The correct answer is B, air contrast enema. Let us talk about a commonly tested pearl on the boards: the distinction between functional constipation and encapresis. Functional constipation is extremely common in pediatrics, and the boards test it frequently. The classic STEM will describe a toddler or school-age child with infrequent hard stools, stool withholding behavior such as crossing legs or hiding, and abdominal distension. The history often mentions painful bowel movements that led to stool avoidance, creating a vicious cycle. First-line treatment is polyethylene glycol, which is an osmotic laxative, combined with behavioral modification including scheduled toilet sitting after meals. Dietary fiber and adequate fluids are always part of the management. Encapresis is involuntary fecal soiling in a child over 4 years old. This is almost always caused by chronic constipation with overflow incontinence. The boards will describe a school-age child with fecal soiling in the underwear and a large stool burden palpable on abdominal exam. The critical point is that this is not a behavioral problem. The treatment is disimpaction first, followed by a prolonged maintenance laxative regimen that may take months. This distinction between behavioral issues and overflow incontinence is a high-yield test point. That wraps up our review of Pediatric Gastroenterology test-taking strategies for Step 2. To solidify your knowledge, make sure you review the Pediatrics and Gastroenterology chapters in First Aid and go through the related question blocks in your question bank. Focus on dehydration assessment, the surgical emergencies of infancy, including pyloric stenosis and intussusception, appendicitis presentations, and functional bowel disorders. Practice applying the age-based approach to abdominal pain we discussed today. For expert tutoring and residency advising, visit roadmaptoresidency.com. Our tutors can work with you one-on-one to strengthen your weak areas and develop personalized test-taking strategies. If you found this video helpful, please like and subscribe to our channel for more board review content. Good luck on your exam.